course, you want to know what kind of nephropathy, potentially the consequence of a specific therapy depending on the clinical situation. These are the three reasons actually.
So in other words, not dissimilar to what we've discussed with primary aldosteronism, it is worthwhile and absolutely necessary to screen for these because it has implications for therapy. We've got another question, Felix.
When you take a look into reasons for secondary causes of hypertension, one of the first is always chronic kidney disease. For me, a secondary cause of hypertension is a potential treatable cause. So is a chronic kidney disease really a secondary cause of hypertension that I could treat, or is that just something I should check for?
Some secondary causes, in other words, some nephropathies you can effectively treat and thereby put them to a relapse without with a continuation of the treatment success. For example, vasculitis, severe vasculitis you treat, and then you can get that. And on the other hand, what you know is if you don't do this aggressive treatment below 140 or 130, blood pressure is the most progressive factor of loss of renal function. And therefore, I think it needs really to respect it. And this is a great difficulty to get these patients to blood pressure goal. And the quality criteria, for example, is at least 80% should be there. And this is very tough to do in clinical practice.
Ronald. Remember, these patients have a coronary history of, a past history of coronary disease.
Yes.
Do you agree again for less than 130?
I would
with the coronary history of coronary disease.
Yeah, good consideration to be concerned about the coronaries. I would like to know in this patient whether he has some symptoms of functionally important coronary stenosis. It's a man, maybe just, it's a fit man we have discussed this morning. So I put in, for example, first I do just an exercise ECG and look at the ECG carefully or whether he has some symptoms. I would like to re-ask that. I do not know what happened in 2002, how solid the diagnosis was, but it was an angiogram, but there was a stenosis who was repeated, but we should, and this is very well taken, we should be concerned about the coronaries, and then we have, of course, we have to judge in an individual stage. Now this patient, fortunately, at the stage he is presenting to me was in the microproteinuria range, so I would go between 140 and 130, in this range, they are absolutely safe. I do avoid to go below 120. That's for sure I not.
This is what we call a consensus.
Yeah, there is consensus on that. Actually, still, nevertheless, all these guidelines, you know, these are not rules. They should guide us and then personalize, individualize our clinical decision. And we also have to weight what is really the major limiting factor. And what is effective for the next 5 years. This may change over the time course of this patient.
Roland, we've got another question here from the audience.
So this is Dieter from Rostock, Germany. So I have a simple question. Do I have to be concerned that I'm doing something wrong to put all my patients with a target below 130? Is there a major disadvantage when I don't have proteinuria to put them below 130?
The only concern, if you're treating them too, let's say it would be too aggressive, what you indirectly saying that is that you may get more side effects which you can cover, which are maybe not so serious, but also side effects which we have just mentioned. You must be careful and avoid to go below 120, this for sure. I don't think you make a mistake in particular to say, well, now here we have a 72-year-old person. Let's say this would be a 32-year-old or 22-year-old person with this kind of renal parameters, maybe due to an EGA nephritis. Then I also personalize my approach and would say, follow your thinking, well, despite the guidelines do not recommend, I would go to a lower target because he has a lifespan, let's say 50, 60 years I have to cover, and then I'm more concerned that even mild changes of blood pressure in the long term, after 20, 30 years, may harm the vessels. So this is really what kind of age. So, going a little step further, I want again to come to the issue of sodium sensitivity. I'm sorry, we discussed it yesterday and this morning, and here one thing is very important. Sodium intake limits any antiproteinuric effect of RAS blockade. That's by the reason, I didn't mention that, why we give a RAS blocker, not only to slow down the progression, but also we want to control proteinuria, in particular those who are macroproteinuria. Now here are 3 quotations or 3 conclusions from papers published a long time ago, and it says sodium intake more than 4 grams reduces antiproteinuric effect of RAS blockers by up to 50%. So if you have a patient, you give him a RAS blocker and you don't see any change in the proteinuria, maybe despite you find quite a good fall in blood pressure, the question immediately should be how many sodium does this patient take in every day? Next point, use of thiazide diuretics only partially restore antiproteinuric effect. Well, this is an old study, and I do not know what it has to, whether still with these newer approaches of diuretics is the same, but really it emphasizes that we should not forget to talk to our patients and to encourage them to reduce sodium. The thiazide diuretic or loop diuretics in patients with a lower GFR is just a tool, but both together maybe should work to restore any antiproteinuric effect. And the last one is one thing which now in the last 10 years we're getting more and more information. We shouldn't think only when we talk about sodium intake that this has something to do with volume, reuptake, volume increase, blood pressure increases. There are more and more evidence that sodium directly causes oxidant stress, has pro-inflammatory signals, pro-proliferative signals, and thereby sodium reduction should be implemented in all events in these kind of patients with chronic kidney disease. To measure it, we discussed it, 24-hour sodium, urinary sodium excretion can be of help to analyze the sodium intake in patients on a stable medication. And finally, one thought, which I think is also important, and there's one study on can we give a RAS blocker along the decrease of eGFR until we have end-stage renal disease? And I want to show you this study. Chinese patients with non-diabetic chronic kidney disease have been put into 3 arms. Now, one arm was with serum creatinine below 3.5. We don't discuss that, that's clear. But what is the case if the patient, and these were randomized, either to an active treatment with a RAS blocker or not, in the range with serum creatinine between 3.5 and 5.0. Now the upper group 1, that's the one with the serum creatinine below 3.5. These have been the randomization process, and as you can see here with an ACE inhibitor, in this case, I would say with a RAS blocker, you found a better long-term follow-up of the primary endpoint, which is a renal endpoint. So, according to this trial, we should be encouraged also to install a RAS blocker, at least to try it, in serum creatinine in the upper range. Now 3.5, 5.0, I didn't calculate, but we're coming to a very low eGFR in the range of 30, 40. It is still worthwhile to start here a RAS blocker. Now this is encouraging. Of course, again, we need individualized to control whether this really indeed helps or not. And finally, coming back to the guidelines, we have the lower part, the upper part is clear. We don't have to discuss that again, we covered that, but the lower part are no-goes. No-goes mean giving 2 RAS blockers in a patient, or no-go is to give a RAS blocker and an aldosterone antagonist in patients with chronic kidney disease due to, and this says at the end, excessive reduction in renal function and of hyperkalemia. You want the proof of that? I was shocked when I have seen these slides. They come from the Altitude trial. And the Altitude trial has an analysis showing, I will guide you to that, if the potassium is below or above 5.0. This is monotherapy, meaning a RAS blocker. This is a RAS blocker plus aliskiren. And you can see here it favors the monotherapy in what cases? If serum potassium is above 5 throughout, if the baseline potassium is above 5.0. And these with respect to hard endpoints, not surrogate endpoints. We're talking about hard cardiovascular renal endpoints. If the baseline potassium is above 5 and patients have been randomized to a dual RAS blockade, they really have cardiovascular renal complications. So really stay out of that, and that was one clear reason why the recommendation, I go back here clearly, that saying no-goes for a dual RAS blockade.
Roland, I know in clinical practice a lot of colleagues out there have concerns to initiate a RAS blocker, in quite low EGFRs. Is there a level, let's assume somebody comes with an EGFR of 22, 23, and we do know if a RAS blocker works, what actually happens initially at least, you do see a reduction in EGFR because intraglomerular pressures are reduced to some extent. That can be a concern if you're so close to stage 5 kidney disease. Is there a cutoff where you would say you would not initiate a RAS blocker in any instance?
First, there is no general consensus, which can be just put here on a slide as a recommendation, but clearly, yes, there is a threshold where you think twice or thrice whether you want to start a RAS blocker, and then you maybe also think about the indication of the RAS blocker. If the indication, let's say if a patient with, make it 22, what you just said, it's 22. Now, usually you can accept a decrease of a RAS blocker by 20%. This meaning it goes down to 17, nearly close, coming close to 15. If the indication is purely to preserve renal function, this is really questionable. Now, these patients have also at the same time a cardiovascular disease, either coronary artery disease, but also in more cases congestive heart failure, and thereby I think it is more important to protect the cardiovascular also in the midterm of this patient and not so much being concerned about the kidney. So I think if it's only would be a renal indication, I would say, well, stay out of it. If it's coming too low, there is a point where the kidneys are destroyed and you cannot save so much of the glomeruli. Also, it might be work. But on the other hand, clearly, if the indication is a hard endpoint with respect to a cardiac constellation or comorbidity, then I would start. I don't care of the kidney. Then it comes freely. The more important is that we preserve the cardiac function, the cardiac coronaries.
About the